Good afternoon, and welcome to our webinar on bedside medication delivery. My name is Jamie Stagg with the Great Plains Quality Innovation Network, and I am a pharmacist and quality improvement program manager on our medication safety and care coordination teams. The Great Plains QIN is the Quality Innovation Network quality improvement organization for Kansas, Nebraska, North Dakota, and South Dakota. We aim to achieve better health care, improved health, safer care, and lower healthcare costs. I'd like to welcome and thank our audience for your participation today. We are fortunate to have representation from a diverse mix of partners and stakeholders from throughout our 4-state region. Today's webinar will be recorded and posted to our website, www.greatplainsqin.org. This will take about 7 to 10 business days to have that recording posted. Slides are available now. I put in chat a link to the location for the slides from today's event. There will be an opportunity for questions after today's presentation. We ask you to please post any questions via the chat function on the WebEx. And I'll be monitoring the chat today to help assist with any questions. Our objectives for today are to understand what bedside medication delivery is and how it can impact outcomes and quality measures, discuss strategies used to implement bedside medication delivery services, and review examples of success stories on how bedside medication delivery impacts patient care. First, I'd like to provide just a real quick overview. Obviously, medication safety is an important issue. Medications play a major role in managing health conditions, but they also can have adverse consequences. Some statistics are that medications can contribute to up to 26% of hospital readmissions. As high as 50% of patients on chronic medications do not take them as prescribed, and non-adherence to medications can contribute up to 25% of all hospitalizations. Bedside medication delivery presents an opportunity to improve in these areas. It involves getting patients their discharge medications prior to actual discharge. Multiple studies have shown the impact of med-to-bed programs on medication adherence and readmission reduction. We are pleased to have a speaker today that has firsthand experience implementing bedside medication delivery programs. Today's speaker is Dr. Oliver Frenzel. Oliver graduated from North Dakota State University with a Doctor of Pharmacy in 2003. His pharmacy experience includes 15 years of combined community and hospital pharmacy experience. He is currently enrolled in the Masters of Public Health program at North Dakota State University. As a pharmacist, his public health initiatives have included medication therapy management, Medicare drug plan selection for patients, and a bedside medication delivery program. He is currently working with an NDSU-based research team to assess the role of reducing and preventing opioid misuse through the OneRx project. We welcome Oliver and his willingness to share his expertise today. Oliver, I turn the floor over to you.
All right, thank you very much, Jamie, and I'd like to thank QHA for the invitation to present to the Great Plains Quality Innovation Network. I appreciate the opportunity to discuss bedside and medication consultation, and I look forward to any questions that you have at the end of the presentation that I can hopefully help to offer some insight into. My objectives today are to review the pertinent questions in the development of med-to-bed and the process of med-to-bed implementation, thereby helping institutions to implement a successful program, and also I hope to provide some examples that hope to answer some of the questions that we're going to be presenting here today. So the first question is, why implement med-to-bed? And we want to improve patient safety outcomes. We want to improve the consultation process. We want to promote a conducive environment for communication between the patient and the family and the pharmacist. We want to, during this conversation, our goal is to reduce adverse medication events due to therapy duplication or therapy omission prior to discharge in that discharge drug regimen. We want to ensure that the patient has discharge medications and instructions, and that the family member and patient have resources, the information, the medications for a successful road to recovery. And if there are any questions or concerns that arise when they get home, that they have that contact information to resolve those concerns and promote that comfort factor with regard to all that information that they receive prior to leaving the hospital or after leaving the hospital. We want to, of course, reduce readmissions to the hospital, and that's becoming a hot topic, especially with the penalties that ensue with regard to readmissions and hospitals not receiving the reimbursements that they would in that short period of time after the initial admission. And our goal is to, of course, improve CMS star ratings. And the last experience that patients have at the hospital is that discharge process. It has a substantial influence on the satisfaction that patient experiences and how smooth the discharge process is, how efficient it is, and how comfortable they are with their instructions and their medications make a big difference in that experience for them on that last day of their hospital admission. And I think of the CMS questions on the patient questionnaire that they get after being admitted to the hospital was the first one, how was the discharge process? And the second question that I think resonates with the med-to-bed process and service is, how likely are you to recommend this institution? And those two questions, I think, med-to-bed can make a serious impact on improving those in those patient responses and improving the satisfaction during the discharge process. So the next question, who benefits the most? And, each institution is going to have their own high-risk group that they would like to focus on or should focus on. And these are just a few examples that I've experienced in my career. The cardiac unit, the congestive heart failure patients, the heart attack patients, CABG, the cardiac interventions like stent placement. And, these are patients that get admitted from the emergency room. They possibly have had a past history of medication use. It's possible that they have never used a medication before in their life. And upon discharge, when they have 4 or 5 or 6 medications that they need to juggle and sort through, it can be very overwhelming for the patient and the family. So I think that's a great opportunity for med-to-bed service to be beneficial. The next example is for COPD or pneumonia patients. They have multiple med solutions. They have multiple metered dose inhalers. They're going home on 1 or 2 antibiotics. And again, it ends up being a lot of information to digest for those patients upon discharge. And it's estimated that between 30 and 50% of individuals that use metered dose inhalers are using them incorrectly. So I think this presents a great opportunity for that individualized consultation between the patient and the pharmacist to reduce that rate of incorrect use and improve patients' quality of life improve their activity level, and keep them out of the hospital. The next select patient would be the surgical floor. This is where I've had most of my experience in the past. I worked at a specialty orthopedic surgical center and same-day surgical center, and these are patients that all the medications that they're receiving upon discharge are brand new medications. They've most likely never been on them unless they've had another orthopedic procedure prior to this one. So there's a learning curve there for these individuals also. They typically go home on multiple pain medications, possible antibiotics, and anticoagulant use to prevent PE and DDT during those weeks or months of immobility. So again, some great opportunities there for the pharmacist to relay on and dispense that information to the patient and family in improving patient outcomes. And also the maternity unit. Medications for mom, medications for baby. With a new addition to the family, there's just an enormous amount of information for that new family when they're going home, and then to add medications onto that, again, is a great chance to improve that comfort level for that family. And each institution is going to have their own high-risk groups. These are just some examples that I wanted to highlight. When you're thinking about your institution and what high-risk groups that you want to focus on for the med-to-bed development, I think two key factors are to think about what patients have the largest medication burden or the most complex medication burden. And the second would be what patients experience those frequent changes to their medication regimen upon discharge. So even if they have been on these medications prior to admission, how many changes are being made at the discharge process? And the one disease that I think about is the congestive heart failure. A lot of those medications do stay the same, but we see a lot of adjustments from hospitalization to hospitalization. Now to get into the development of the med-to-bed process and who's going to initiate that med-to-bed conversation to the patient. And it really depends on the scenario and the structure of the institution that you have. It could be the admission nurse, it could be the discharge nurse, it could be the pharmacist or pharmacy technician, or it could be the physician. And I have two really good examples. One of them was an institution that I consulted for. They had been having some trouble with their efficiency in their med-to-bed program, and they were having one of the pharmacy staff go up to the patient's room and discuss the program to the patient. And then if the patient accepted that, then they would go back down to the pharmacy. They would get the medications filled. They would have another staff member go up to the room and do the co-pays for the prescriptions that they were getting discharged on. And then they would go back down and get the medications, and then the pharmacist would then go up and detail the medications. There were many, many trips back and forth, and it was very time-consuming. And it wasn't efficient, it wasn't optimal, and it made the patient wait extremely long periods of time, and they were starting to be dissatisfied. An institution that I actually staffed at, I had a success story from, and it was patients that were admitted into the hospital. The admission nurse was the one that presented the program. They would explain what the pharmacist would do, when the pharmacist would deliver the medication, and at that point in time, the admission nurse would then change the preferred pharmacy in the electronic. If they volunteered for this service and participated in the service, the nurse would then change the preferred pharmacy in the electronic medical record to indicate that in-house pharmacy at the hospital. And then the nurse would also call the pharmacy, explain that they're going to get their medications there, and they would also assist in keeping down insurance cards if that was needed for prescription-specific insurance cards. And it worked out tremendously well. We had just a great amount of success in doing that. And part of that was the great relationship the nurse already had with that patient during that admission process. And then the other flip side of that is that the nursing staff in that admission unit were also highly promoted the program. And they were accepting of that program, knowing that it took a big burden off of the family and the patient's shoulders, not having to wait or make another stop at another pharmacy on the way home after discharge. So our next slide, how to implement med-to-bed. And I can't reiterate this enough, is to start small. We all have big expectations sometimes, and we want to start with too many different patients with a startup program in the institution. But try not to get overly ambitious at the start. Having too many patients and too many wrinkles to iron out at the beginning could really end up in failure and having patients waste long periods of time, which is very dissatisfying to them. So try to use only one floor and focus on one disease state when you're initiating a program like this. Make sure that you have the staff that can adequately fill the prescriptions, but then again, make sure you have the staff that adequately can take care of that patient and allow for a good conversation and consultation for that patient's benefit. And then also, when you're starting, ask for input from the providers, the nurses, and the quality control department. And I think this is really important because sometimes, as a pharmacist and working in a hospital pharmacy, sometimes we don't know what the high-risk patients are. We might have a guess, but nurses and providers really do have a great insight into that. And they know what patients are readmitted, and they see them come back, and they have a better relationship with them, and they can identify patients that maybe need that extra time spent with them to prevent any adverse outcomes. So really value their input when you're developing a program like this. They can be a great asset. The next point, where's the best place? And that would be, in surgical units or same-day surgery units, you, again, asking the nursing staff, where's the best environment conducive to have that medication consultation? Is it the PACU? Is the family member there, or maybe the family member isn't in the PACU? Maybe it's the phase 2 recovery or the acute recovery unit when the family is there and they're able to eat and drink and they're getting ready for transport to take them out of the hospital. Again, I don't have an answer for each specific institution, but it's a question that you need to ask and logistically try to fit that into the best environment that benefits the patient the most. And then when is the best time? You always, in my experience, if you can coordinate the med to bed either at the same time or right after the nurse has gone over the nursing summary and the after visit summary, which includes the medication list, the changes to medications, their upcoming appointments, it works out really, really well. That way they have a piece of paper that notes can be written on along with the bottle of medication that they're going home with, and it offers that extra layer of information for the patient and family. So that timing can be tricky, but it really makes a big difference with regard to when that patient goes home. And we always want to make sure when we say when is the best time, we always want to make sure that the medications are delivered immediately prior to leaving. If there's any chance that a patient is going to be not discharging and leaving the next day, you don't want to leave those medications with that patient. If they're staying another day, there's most likely some recovery issues that the provider and the patient are trying to work out, and you can be sure that there'll be adjustments made to those first discharge medications the next day because of those those circumstances. So after you have a plan developed, you want to communicate with the care teams. So you already know why we're doing it. We know when we're going to do it. You know how we're going to do it. Now that we have our process all put together, we need to inform the whole care team of what we're going to be doing. Pharmacists should be detailing the nurses and the physicians on the med-to-bed services. We want to make sure that they know who is going to be targeted, when they're going to be targeted, what times of the day, what days of the week it'll be offered, so that everyone is in the know. And the institution that I staffed at, we had a nursing director that had said, this is such a great program, we need to make sure that everyone knows about this. Can you please come up and attend our nursing huddle? And they had a nursing huddle once every day for 10 to 15 minutes each day of the week. And a member of the pharmacy staff or myself went up to the nursing huddle, and we just gave them a little preview about what was happening, when we were going to be doing it, the day of initiation of the services. And everyone was on the same page, and it was received so well, and it ended up being such a successful program. And I have to attribute a lot of that to the nursing staff on that floor, because they had the information, they were able to relay that on to the patient and family, and made a tremendous difference in the success of the program. Another question you need to ask, how to address copays. So are you going to use a remote register tablet with credit card capabilities? Are you not going to worry about the exchange of money in the hospital room or the recovery unit, and you're just going to put them on a charge account? That's just another one of those logistical questions that you need to ask prior to the start of the program. And to ensure a successful program, you have to be committed. And it's not just the pharmacy that needs commitment, and it's not just the nursing staff, and it's not just the physicians. It really needs to be a team effort. There has to be excellent communication between the nurses and the physicians and the pharmacists. I can name numerous examples of the relationship that I had with the nursing staff, and the numerous calls that they would come down to the pharmacy explaining to us when the patient is going to be doing PT, or when they're going to be doing OT, when the patient's family member is actually going to be here to take them home. Please come up during that period of time. So there's another set of ears there to listen to that consultation. Or if there ends up being a complex regimen or an unusual medication, we get numerous calls from physicians kind of giving us a heads up saying, this patient I really want you to spend a little more time with, just to ensure that they know how to take this medication and that we don't have any tragedies when they get home or adverse events when they get home. So the communication back and forth really in that triad between physician, nurse, and pharmacy really is important. And then the benefits, and we talked a little bit about this earlier, you'll have, with a successful program, you're going to have improved relationships with physicians and nurses in that coordination of care. And it ends up being, it takes a big weight off of the physicians and the nurses, knowing that patients have the medications that they're going home with, knowing that the nurse has gone over the after-visit summary and the medications, and the medication information. But then the pharmacist has also come up, and they've gone over the medication information again. And it's that reiteration over and over and over, and that comfort factor with everyone in the institution that makes it such an important program for preventative care. Some examples of the patient safety topics and the questions that I received when I was staffing in the med-to-bed was the review of the last dose of the hospital meds and timing out the next dose. And a lot of patients and families knew they were on an IV antibiotic, for example, and they're going home on an oral antibiotic. And when do I take that, and how do I coordinate that with my home medication? Was a very frequent question. Clarifying formulary changes from hospital to home medication is very concerning to patients and families when they're on a formulary metered dose inhaler in the hospital, but they're going to be stopping that now, and they're going to be going back to their regular metered dose inhaler at home. And frequently you have the change of colors on the metered dose inhalers. You have different directions. You may have an aerosol spray compared to a dry powder inhalant. All those things are big changes for the patient. And by spending that extra time during that consultation period makes a big difference to them and their comfort level. And then overcoming obstacles to medication fills. The cost is a big one. When the pharmacist is able to take those medications up, go over the medications and also show the patient what the copay is, you will have some patients that say, I cannot afford that, or I do not want to pay for that. And that just presents a great opportunity to coordinate with the physician to come up with a therapy plan that you know the patient is going to go home with, but then you also know the patient is going to take because you've overcome that uncomfortable barrier there with them. The travel and wait time at community pharmacy, and we ran into that working in North Dakota. Some individuals had very long trips home, and there was always that worry, am I going to get to my hometown pharmacy in time to pick up my medication so I can take my next dose, or should I just get the medication here knowing that I can take tonight's dose and the next morning's dose and not have any interruption there? And that can make a big difference with regard to outcomes in acutely ill patients being discharged from the hospital. And then non-covered medications, as we see the cost of medications rising month to month, that ends up being a concern for patients and for pharmacies. And when those non-covered medications can be addressed in-house at the pharmacy, and the physician can be communicated with to come up with therapy alternatives, that makes a big difference to the outcome of patients. And it also makes a big difference knowing for the providers that the patient has the tools and the resources they need to a good road to recovery. So all these things kind of build that reputation for a patient-focused institution. And that's why I feel that the med-to-bed program can make such a tremendous difference. And in summary, asking those questions, the why, the who, the when, and the how. Why are we doing med-to-bed? The second question, who are we going to be targeting for this med-to-bed service? When are the services going to be available to both the patients but also the other staff members so that everyone is on the same page as patients are being detailed on it? And then also, how are we going to educate the staff, and how are we going to coordinate delivery to promote improved patient care during bedside medication consultation? So if you jotted down these questions, you ask yourself these questions and can put some answers behind them prior to the implementation, it will ensure you have an excellent foundation for a successful program and improve patient outcomes in the future. And Jamie, that is all I have. I will hand it back to you.
Okay. Well, thank you to Dr. Frenzel for providing that overview and sharing some of your experiences and expertise with us. We will start to answer or do Q&A now, and I know that there's some people on here that also sounds like they might have some experiences with med to bed or are looking into it. A couple of questions that we have in chat, Dr. Frenzel, is looks like we have a few hospitals that don't have an outpatient pharmacy in their facility. So they'd have to look at, working with the local community pharmacies for this type of service. What type of advice or tips would you have for a program such as that?
I would have two pieces of advice. The first one would be is we'd want the nursing staff and the physician would want to make sure that the pharmacy was aware of the discharge time so that they delivered the medications at an appropriate time that is in sync with all the other activities during the discharge day. And the second piece of advice I would say is the pharmacists, as they're doing the med-to-bed consultation, if at all possible, it would help out tremendously for the discharge nurse to also be there with the after-visit summary. And the reason is that there are so many questions from the patient and the family member that come up as you're going over those discharge medications that if that pharmacist works at a community retail pharmacy and they don't have access to that electronic medical record, it makes it very difficult to give them clear instructions, adequate instructions, safe instructions during the discharge process. And if a nurse is also there with the after-visit summary, able to help look up that information for the pharmacist, that can make a tremendous difference in the efficiency and the information exchange between the pharmacist and the patient and family.
Okay. Thank you. Another question is related to understanding the charges to a patient. If you could just clarify, you were talking about setting up a charge account or using a credit card. Just explain what those charges are for. Is there a charge for the actual Meds to Bed program, or is the charge just associated to their out-of-pocket expenses for these outpatient prescriptions?
Yeah, I apologize for not clarifying that. No, the institutions that I have familiarity with, there was no charge for the Med to Bed service. The only charges that were incurred were the actual co-pays after processing the medication insurance through the third party, and then those co-pays being presented to the patient and the family. So those are just the co-pay receipts or co-pay slips, exactly the same as a co-pay slip that they would have at a retail pharmacy. So no extra charge incurred for the actual service of the Med to Bed and that time spent. No.
Excellent. Okay. That clarification. Another question here is looking for clarification on who's doing delivery and consultation. Is this the pharmacist from the outpatient pharmacy, or is this a hospital-based pharmacist that's doing the bedside consultation? Along the same lines, who's doing that delivery then? Is it a nurse or a pharmacy technician or the pharmacist? What are some of the examples that you've seen on how that's done?
Sure, and that's a really good question, and it's funny that came up, and I felt like I should have had that in the presentation. I apologize for that, because I had a question just last week from an institution. They were asking me that same thing: is who if there is a retail pharmacy and there is a hospital pharmacy, who really should be doing that consultation? And in from my experience, I feel that if there's a clinical pharmacist at an institution that works on the floor, it's probably easier for the clinical pharmacist to do the med to bed. And the only reason I say that is because they have followed that patient for the last 2 or 3 or 4 days, however long they have been in the hospital. So they know a little more history on that patient. It could be much easier to transfer that information to the patient and family when you have the history to go off of by saying, you remember you were on that IV antibiotic every 12 hours? Well, you're going to go home with these pills, and these pills are every 12 hours. And they're just a little more privy to that inpatient stay for that patient. If, in my opinion, if there is not a clinical pharmacist that actually works on the floor, and maybe there's just a central pharmacy location where medications get tubed up, it would be more appropriate to have the community retail pharmacy do the consultation. Mm-hmm. And the only reason I say that is that if there were questions with copays or insurance, I think I know the retail pharmacist would be a little more in the know with regards to those questions, and also do just as good a job, and if not better, consultation of those discharge medications in that situation. Again, those are just my opinions and from my experience that I've seen, but I think those would probably be an instance for either one of those that would promote the most efficiency during the bedside consultation visit. I hope that answers the question of those two scenarios.
Yes, I think that was a good job. If there's follow-up questions, please keep on coming in chat. We've got, this is nice to see. Let me look here for the next question. Let's see, that one we kind of already addressed with what to do if the hospital doesn't have a retail pharmacy. So here's a good question. How do you work with the patient's regular pharmacy and primary care provider with the medications that occur? You know, like you use the example of they're not sure that they're going to get home in time to get their medications from their home pharmacy, but how do you work about communicating that for the future refills and that?
Yeah, that's a really good question, and that is I'll give you an example. For instance, when I worked on the orthopedic floor and we had individuals that were discharging with Eliquis, and to prevent PE or DVT. And it's possible that just one fill would get them through, but it's possible if they were high risk or they have limited mobility, the physician wanted to extend that therapy to maybe a month and a half or 2 months. That was something that we always reiterated to the patient and the family is, here, this is a month's supply of medication. We value the relationship that you have with your community pharmacy. We don't want to take away from that service that you have at your community pharmacy. Have your community pharmacy call us when you get down to 2 or 3 days supply of that medication so that we can transfer the refill to them and you can continue your full therapeutic duration. Don't stop short just because the hospital is an hour and a half away. Please have them call and ensure that you have the adequate therapy that you need to prevent any adverse outcomes. So that was always relayed on to them is that we were more than happy to transfer that prescription, and we made it well aware to the patient that it needed to be transferred if they were not in a location that could pick up from the hospital pharmacy or the retail pharmacy located in the hospital.
Okay. We have another question related to, are you aware of programs like this with nursing homes for when nursing homes are discharging residents?
No, I'm not. I have not heard of any programs with regard to nursing home discharges. I think that would, with an individual discharging from a nursing home, I think that would be an excellent opportunity with individuals in a nursing home, and they're there for, anywhere from 2 weeks to a month to multiple months, and the nursing staff is taking care of the medications. That can certainly be, it can certainly blindside the patient and the family member when they have all these medications and they're not sure when to administer them or how to administer them. I think that would be a great opportunity to relay on the information for the family and the patient from the pharmacist's perspective.
Yeah.
Yeah, absolutely. I've never thought of that, but I think that would be and I think it would be influential time just because the nursing home resident and the family is so possibly disconnected with the medication regimen that the patient is on. I think that could have some really positive benefits to that family and patient, certainly.
Yeah. Yeah, I mean, I can share from my experiences that I'm aware of a few nursing homes that have done this, especially with residents in their transitional care units. They've really targeted those individuals. The example that I'm familiar with is when their long-term care pharmacy also has a retail location as well, so that's kind of how they transition them over to their outpatient services. I know of one example even where how they handled the education process, the medication education process, was that they had pharmacists discuss with the patient and family via an interactive connection. So the pharmacist actually wasn't physically present, but they used, Skype, for example, as a way to communicate and do that education. So I do know that there are some facilities that are using meds to beds, and there's some creative ways that they're going about that.
Yeah, that's fantastic outreach. I was not aware of that, but that's excellent to hear. Wow.
So we had also in chat, we have a few comments regarding, making sure, this was kind of along the communication and coordination with the outpatient pharmacy and primary care, is to make sure that the entire discharge list is sent to those pharmacies so they can kind of view the medication history on what happened during the stay, as far as what's been discontinued, what's new, what's been changed, along those lines. And I think that kind of goes along too with Oliver, with what you were saying about the importance of the after visit summary as well with that.
Yes, absolutely.
Looks like that's what we have in chat. What I'd like to do right now is I'm going to change the mode on the conference call to what we call question and answer. So what this does now is this allows everyone that's on the conference call, you can unmute yourself if you want by hitting *6 And when you do that, you'll be unmuted, and then you can ask a question over the phone if you prefer to do things that way. The other thing that I'm kind of curious about that I'd be looking for audience participation on is if anyone's currently doing this within their system, or if they're looking into it and some of the successes that you've had or challenges that you've faced. So once again, please use *6 to unmute yourself and ask your question or share your story.
Hi, Jamie. This is Marcy Schultz in Haven.
Hi, Marcy. Go ahead.
Hi. I just wanted to talk about the program that we're starting at the Cockaville Medical Center in Haven. And, again, we're still working towards it. We'll be going live here soon. We have it built into our EMR that the nurse will discuss the Meds to Beds program with the patient, get their preferred pharmacy. She'll give them the brochure about our pharmacies that we have locally, the hours that we do, the discharge medication, and the consultation process for when they get discharged. How we worked it out is the provider then, on day of discharge, will prescribe those medications to those pharmacies. That pharmacy will then fill those prescriptions. If the pharmacist is available from either Haven or Beulah, they will come to the bedside, deliver those medications, and consult the patients. If the pharmacist is not available to do that consultation, they will send a pharmacy tech, and the pharmacy staff member pharmacist at the pharmacy has an iPad, and then we have an iPad at the hospital, and that pharmacy tech will ask for the iPad at the hospital, take it into the patient's room, and then they will do like a business Skype, so it's secure, back to the pharmacist, so that pharmacist can do the consultation for that patient. For payment, we worked out that they can do credit card at that point, or they can do cash and pay the pharmacist or pharmacy tech upon that time. Our pharmacies both agreed to do a charge account also for those patients that want to charge, and they can set up an account for them. So a little bit of a glimpse of our program that we're getting ready to launch.
Excellent. So that's a good example. So now, Marcy, you're a critical access hospital, right? And so you're partnering, this is a situation where you're partnering with the community outpatient pharmacies to provide this service.
Yep, that is correct. We're partnering with Haven Drug and Beulah Drug, and we've been meeting with both the pharmacists from both organizations. I collected data for about 4 months from our ER and our inpatient, and I looked at the preferred pharmacies. I had the nurses collect the data, looked at the preferred pharmacies out of those two settings, and then I also looked at the discharge time out of those two settings, and then did some pivot tables just to look at so that we could have the pharmacy understand when the most appropriate time for them is to increase staffing or when they can expect to be coming back or to the hospital or for the ER or the inpatient side. So we wanted to make sure we had some data to back that up also.
Well, thank you for sharing your story. That's a great example of community partnerships as well to accomplish that. Are there other questions or individuals who would like to share your experiences? Once again, please use *6 to unmute yourself, and then after you shared your experience, you can use *6 to put yourself back on mute.
I just wanted to say this is Julie at Avera Mary House in Pierre, and we have some instances where we have a transitional care unit here, and so we have people that are on Medicare while they're on getting therapy, and then when they go off Medicare, they aren't able to pay for, say, Eliquis. And so we've had patients that just don't pick it up at the pharmacy and then don't go on anything because that's the prescription that was sent home with them. So we're trying to figure out ways to talk to the patient and get that cleared up before they go home to make sure that that's not going to be an issue, and if it is, to use an alternative like Coumadin or something so that they don't have the issue of not being able to afford their medication.
Yep. That's a good example of why this type of program is helpful in addressing those needs prior to them leaving the facility. The more that we can address while they're still under your roof, the better. Oliver, do you have any comments based on those last couple of examples that have been shared?
No, I think the example out in Beulah, I think that's fantastic that the institution is partnering with the local retail pharmacies, and the local retail pharmacies are willing to make that extra trip up to the hospital to do an individualized consultation. I'm really happy to hear that. It's fantastic partnership there between the hospital, in a rural setting, between the hospital and retail pharmacies. And the second comment where the individual had mentioned the like the Eliquis and transitioning from the transitional care unit and going home, and there's a similar example that I consulted for at an institution where individuals were having cardiac interventions. They had stent placement, and they would stay in the hospital for a day or two, and then the physician was prescribing Brilinta to their local pharmacy, and the patients were getting to the retail pharmacy, and Brilinta either was not covered or the copay was just extremely high, and they were refusing it, and patients were coming back for their follow-up visit in 2 weeks or a month with their cardiologist. And after discussion, the patient would say, no, I can't afford that, I'm not taking it. And the whole cardiology staff about went through the roof, wondering how situations like this can be averted. It's so scary to have someone with an cardiac intervention like that, and stent placement, and not be on an antiplatelet medication. So again, just another really good example of some of the great things that pharmacy can do at preventing a tragedy and a poor safety outcome from just a little bit of communication and consultation before they go home.
Well, as we wrap up here, I just want to highlight an upcoming event. A week from today, at this same time, the Great Plains Quinn is hosting a medication safety webinar on overcoming the challenges to treating patients on opioid and benzodiazepine therapy. The nice thing about this is that for the event next week, there will be free CME offered with this. There's a link on the slide to register for the event, so please feel free to do that. And we'll hopefully see you next week. We ask all attendees to complete the form for today's event to offer us feedback and help us plan and coordinate future events. We want to ensure we're meeting the needs of our partners. Your input is important. Please use the evaluation to provide the topics you want us to address in the future through our medication safety series. The evaluation will appear when you exit today's webinar. Please feel free to contact the Great Plains Quinn Medication Safety Team with any questions. We thank you all for your participation today, and to Dr. Frenzel for sharing his expertise. We hope you found the information valuable. This will conclude our call. Thank you, everyone.